Vietnam Burn Association for giving me the opportunity to present my patient here. So my topic is the diabetic foot reconstruction. Okay, so we want to reconstruct the diabetic foot. We have to know the cause of the diabetic foot. So a lot of patients come to meet with the diabetic without knowing they have some problem of the diabetes, especially the peripheral neuropathy and the peripheral arterial disease and the deformity. I think the three causes is the most important to the diabetic foot. Sorry. So diabetic foot with the peripheral neuropathy, it's very important because they don't feel anything. So when they come to us, there are a lot of abscess formation, there are a lot of ulcer, and there are some nicotine fasciitis. So you have to be careful of this patient. So my suggestion is you do the peripheral neuropathy examination with the small fiber and large fibers. So you do the examination before they have the ulcer. So that's very, very important. So next important thing is the peripheral arterial disease. That's the PAD. So you have to do the 5P examination of the patient. Do they feel pain? How is the pulse of the foot? And are they pale? Are they the sensation? And are they paralysis? So if they have the rest pain, and then people have the capillary fill time. So we have to check that for evaluation of the peripheral arterial disease of the diabetic foot. So intermittent coagulation is very common in those diabetic foot patients. So in the POD patient of the diabetic foot, we have to do the ABI examination, just like this one. We do the pressure examination because in diabetic foot, there are always occlusion of the artery, especially the small artery. So this is the valve, so the occlusion will stop the flow of the flow. So this is the team of our in my hospital. They do the endovascular measure of the peripheral vascular disease. So they will do the CT guidance to do the cannulation of the artery. So if the artery can be cannularized, so the blood supply will be restored. Also, in this case, there are two occlusion sites in the iliac artery. So they do the cannulation, so the blood supply will be restored. I think this is very important in the reconstruction of the diabetic foot. So we always cooperate with our endovascular team in our hospital to increase the blood supply first, then we do the reconstruction. So this is the vascular team. They do the vascular cannulation. So this is the before, this is the after. After that, the low limb, the secretion increase, then the ulcer can be healed. So that's very important. So we always do the POD evaluation before the reconstruction. So the third problem is the deformity of the foot. So we always see some charcoal foot or some knuckle or some deformity of the bone in our patient. So in those patients, we have to manage those deformity before we do the reconstruction. Maybe we do the osteotomy or do anything to do the joint. So the diabetic foot it's a step by step. You have to offloading of the plantar ulcer. Then if it's not, you go to the advanced wound therapy. So you have the debridement of the necrotic tissue, and then you have to revascularization of the ischemic foot, and then you have to management of the infection. Then you use physical topical dressing. So those are very important. I saw the VAC in the outside. So I think we use that a lot in our patient. So this is the offloading device. So this is the shoes of offloading. So we do that to our patient a lot. So before we have do the sulcus artery perforator flap in the reconstruction. So we especially we use the sensor flap because we harvest the TDAP flap with the intercostal nerve. So the first we do the sonography to evaluate the blood supply of the TDAP flap. So we first define the perforator. It comes from the sulcus artery, then it go to the cutaneous part. So this is the perforator. This is what's the muscular perforator. This is the cutaneous perforator. So we define the perforator, then we can harvest the flap. Then we can harvest the flap without harvesting the LD muscle. So we do the Doppler first, then we do the harvesting. So this is the subcutaneous perforator. This is the muscular cutaneous perforator. So we do the harvesting of the flap without injury of the LD muscle. So in this case, we reconstruct the hand defect with the LD. We can harvest a small flap with the nerve inside the flap. Then we can reconstruct the soft tissue defect and the nerve defect together with one flap. So this is the perforator. So we can define the perforator very accurately. So also we do the sensitive sulcus artery perforator flap. So this is the sulcus artery perforator. So this is the intercostal nerve. So the intercostal nerve always comes with the lateral cutaneous nerve. Then it goes with the perforator. So we can harvest the perforator here, and we can harvest the nerve here. So this is the conjoint area of the nerve and of the perforator. So this is the muscular cutaneous perforator, and this is another intercostal perforator. So we can harvest the nerve together. So this is the intercostal nerve. So this is the outer perforator. So in the construction of the low leg, so we can harvest the flap together with the nerve, and this is the conjoint point. And together we can do the sensitive sulcus artery perforator flap to reconstruct the defect. So this is the follow-up of our patient. So we do the sensitive evaluation 6 months after the operation and 12 months after the operation. So in the central part and in the peripheral part. Then we saw some difference. We found no difference in the flap size between the flap. We do the sensitive and the group we do not do the nerve harvesting. So the test showed that in the central part, the sensitive flap has the most sensation, less 2 dp at 6 months and 12 months. But at the peripheral part, the group no difference on 6 months, but there are difference on 12 months. So the sensitive flap is useful in those areas near the sensation, such as in the reconstruction of the hand, finger, or maybe penis. So we have the publication on the grabs as a companion of flaps the chapter. Also, we do the ICG evaluation of the flap during the operation. So we check the flap during the operation with the ICG. So this is the melanoma case. We do the lymph dissection. So we use the ICG to evaluate the blood supply of the flap. And we found out that this flap and this breast is not vascularized because there's no fluorescent in the ICG evaluation. So we size those without the vascularization, then we close the wound, and the wound will be okay. Also, in this case, we do the ICG in this case. So we have a very large flap, TDAP flap, and we do the ICG evaluation, and we found in the distal part, just this small part, do not have the blood supply. So we remove this part. And we evaluate the size. We found out that Total flap size is about this one. And in intraoperative, we evaluate with HG, it's about 61. In postoperative, it's 60. So it's about the same of the ICG and the postoperative. But if you do not do the ICG, the size will much different. That means that ICG is useful in defining the vascularization of the flap. So I would like to present a similar case of my patient. So in this case, this is a diabetic foot. So we always do the debridement first. We do a serious debridement, several times debridement before we can do the reconstruction. So this one is 40 years old. His right foot gets infection, but he did not notice. That means that he had a peripheral neuropathy for a long time. So after the debridement, bone and tendon exposed, just like so we remove the second, the third toe, and we do the fasciotomy, and we open the wound, we remove the bone. And we do the vascular evaluation. In this case, it's 40 years old, we do the API evaluation, and it's normal. So we do not need to do the reconstruction by the radiologist. So then after some serious debridement, the wound become more clear. But we still remove the bone here and the tendon here. There are some tendon remaining in the wound. So in the last step, we do the reconstruction. We do the sonography to evaluate the blood supply of the flap first. So we do the parameter evaluation. So those are parameter we are going to harvest with the flap. So the parameter is transverse, so we do the transverse harvest of the flap. So this is a big flap. We harvest the 26 times 7.5 centimeter large flap from the back, from the transverse. So we harvest this one with reconstruction from anterior to the posterior. And we do the analysis to the anterior tibial artery and the collateral circulation, collateral vein. So the donor side is invisible, it's minimal mobility, so it's acceptable donor side mobility. So this is another case. This is a 72 years old female. She got a lot of severe infection of the left leg with the devastating fasciitis, the skin necrosis, the fascia necrosis, accidental exposed. And there are still, so we debride the window, we remove all the skin and the fascia, and there are a lot of defects there. So this 72 years old with tendon exposed, so we harvest the TTAP flap with 10 to 30 times centimeter flap. We do the sonar evaluation of the flap. And this is the flap we harvest. Also, we have some LD muscle flap together to cover the lateral side of the defect. So this is the medial side we cover with the TTAP flap. The lateral side we cover with the LD muscle. So this so we can do one flap, but with cover a large defect. So this is this one we cover the defect, and this donor side is minimal the comorbidity. So the lateral side we cover the LD muscle and the SDH. So so we just one fiber we add some mercy to the posterior tibial artery and collateral vein, and this is a follow-up. So in conclusion, we think the diabetic foot is very important, especially you need to prevent the ulcer. So you have to do the early recognition, you have to do the diabetic neuropathy evaluation. So you can do the NCD evaluation to recognize the neuropathy. So those at risk feet usually control the sugar, and then you control the complication. Then in reconstruction, you need a multidisciplinary approach. That means that you need help from the radiologist, you may need from the neurologist. So you can do the vascular reconstruction first by the radiologist, then we can do the reconstruction. And the sarcoidosis perforated flap is an option for soft tissue reconstruction because it has minimal donor site mobility and it has a long pedicle and you can hug with the LD muscle, so you can reconstruct a large defect. And also ICG is very useful to detect rupture supply of the flap. Thank you very much.